Have you ever started a new blood pressure medication and a few weeks later, your stomach just wasn't the same and nobody connected the dots? Not your doctor, not your pharmacist, not even you. Stay with me because by the end of this video, you're going to understand something that almost never gets explained in a cardiology appointment. And it might be the missing piece for a problem you've been dealing with for months, maybe years, without ever blaming the pill bottles sitting on your counter. I'm William Lee, and I'm a gastroenterologist, which means people are often surprised I'm the one making this video. You'd think this topic belongs to a cardiologist, and in some ways it does. They're the ones prescribing these medications. But here's the thing. The side effects I'm about to walk you through almost never show up in the cardiologist's office. They show up in mine. Someone gets referred to me for chronic constipation or unexplained bloating or a cough that won't go away and somehow turns into a reflex workup. And when I pull up their medication list, there it is. A blood pressure drug that's been quietly messing with their gut for months. So today, I want to give you the conversation that happens in my exam room, the one your cardiologist genuinely doesn't have time for in a 15-minute visit, because their job is your heart, and mine is what happens after the medication leaves your stomach. Let's start with calcium channel blockers, because this is the one I see constantly. Drugs like amlodipine, nifedipine, diltiazem, verapamil, these are incredibly common, especially in patients over 50. What most people don't realize is that these medications don't just relax the blood vessels in your heart and your arms and legs. They relax smooth muscle everywhere in your body, including your intestines. Your gut relies on smooth muscle contractions, we call it motility, to push food and waste through your digestive tract. When you slow that muscle down with a calcium channel blocker, you slow down the whole transit system. The result, for a huge number of patients, is constipation. Not occasional, mild, annoying constipation, but the kind that builds over weeks, gets worse over months, and eventually leads to straining, hemorrhoids, sometimes even small tears that bring people into urgent care, convinced something is seriously wrong with them. And here's the part that really gets me. Most patients have no idea their blood pressure pill is the cause. They start taking fiber supplements. They try laxatives. They blame their diet. They blame aging. And the actual cause is sitting in their medicine cabinet the entire time. Verapamil tends to be the worst offender of this group. Amlodipine a bit less so, but all of them carry this risk to some degree. If you're on one of these and your bathroom habits changed after you started it, that's not a coincidence you should ignore. Now, let's talk about ACE inhibitors, medications like lisinopril, enalapril, ramipril. Most people associate these with one very specific side effect, the dry cough, and that's real. It happens because of a buildup of a compound called bradykinin in the airway. But what almost nobody tells patients is that this same bradykinin pathway can affect the gut too. Some patients on ACE inhibitors develop a condition that genuinely confuses doctors when they first see it: intestinal angioedema. It's rare, but it's real, and it causes sudden, severe abdominal pain, sometimes with nausea and vomiting, that can look exactly like an acute abdomen, the kind of presentation that sends people straight to the emergency room for a CT scan. I've seen patients go through extensive workups, sometimes even get scheduled for exploratory procedures, before someone finally asks the right question, "Are you on an ACE inhibitor?" and stops the medication, and the symptoms resolve completely within days. This is rare enough that I don't want you panicking over it. But if you've ever had unexplained, severe abdominal pain that came and went without explanation while you were on one of these drugs, that's a pattern worth bringing up directly with your doctor, by name, because most physicians outside of GI have simply never been trained to look for it. Diuretics are next, and this is where things get interesting, because the gut effects here are less about the muscle and more about chemistry. Diuretics like hydrochlorothiazide and furosemide work by pulling fluid and electrolytes out of your body through your kidneys, but that process doesn't always stay neatly contained to fluid balance. When your potassium and magnesium drop, and this happens more often than people realize, your gut motility can drop right along with it. Low potassium specifically can cause something called paralytic ileus in severe cases, which is essentially your intestines slowing to a crawl because the electrolyte signaling that tells your gut muscles to contract simply isn't there anymore. In milder, more common cases, this just shows up as bloating, gas, a general feeling that digestion has slowed down. If you're on a diuretic long term, this is exactly why your doctor should be checking your electrolytes periodically, not just your blood pressure number, because the blood pressure can look perfectly controlled while your potassium quietly drifts into a range that's affecting your entire digestive system. Beta blockers deserve a mention here too. Drugs like metoprolol and propranolol, because they have an effect that catches a lot of patients off guard. They can blunt the normal nervous system signals that regulate gut motility and appetite. Some patients described feeling like their digestion just feels sluggish, less hungry than usual, slower to feel full or finish a meal properly. It's not dangerous in the way intestinal angioedema is, but it's disruptive. And again, almost nobody connects it back to the medication because the connection simply isn't common knowledge, even among many primary care doctors. Here's where I want to bring in something most people have never heard of. The timing of when you take these medications relative to food actually changes how much of this gut disruption you experience. Taking certain blood pressure medications on a completely empty stomach can intensify gastrointestinal side effects because the drug hits your stomach lining at a higher concentration before anything buffers it. Taking it with a meal, particularly calcium channel blockers, can soften that impact considerably. This is the opposite of what a lot of patients assume. They think taking a pill on an empty stomach means faster absorption and better effect. And sometimes that's true for blood pressure control, but it can come at the cost of your gut. And for some people, that trade-off isn't worth it, especially if constipation or bloating has already become a daily problem. So here's what I actually want you to do with this information. I'm not telling you to stop your medication, and I'm definitely not telling you your cardiologist did anything wrong. Blood pressure control is genuinely one of the most important things you can do for your long-term health, full stop. What I am telling you is that the gut side effects of these medications are real, they're common, and they're almost never explained at the time of prescribing because that conversation falls in a gap between specialties. So, bring these questions to your next appointment. Ask whether your specific blood pressure medication is known to affect gut motility. Ask whether taking it with food versus on an empty stomach makes a difference for your specific drug. Ask if your electrolytes are being monitored regularly if you're on a diuretic. And if you've had any unexplained abdominal symptoms since starting a new blood pressure medication, say that explicitly, in those words, because it changes how your doctor investigates the problem. If this helped you understand something your own doctor never had time to explain, do me a favor and send it to someone you know who's on blood pressure medication and dealing with digestive issues they've never connected to their prescription. Because this is exactly the kind of gap between specialties that leaves patients suffering for years over something that has a simple explanation. I'm Dr. Patel. I put out a new video like this every week because I think patients deserve to understand their own bodies and their own medications fully, not just the part that falls under one specialist's job description. Subscribe if you want more of these conversations, the ones that happen between specialties instead of inside just one of them.